And I am really happy to introduce to you Dr. Carolyn Parsey. She is a clinical neuropsychologist with UW Medicine Memory and Brain Wellness Center and an assistant professor in the UW School of Medicine Department of Neurology. Her clinical work involves assessment and diagnosis of dementia, as well as advocacy work with the Dementia Action Collaborative of Washington State. And her recent research pursuits have evaluated the social and economic impacts of COVID-19 on people with dementia, their families, and the organizations that support them. So she's got great expertise to share with us today about dementia care during COVID-19. Thank you so much for being here, Dr. Parsey.
Thank you so much for having me. So I'm excited to talk to you about a handful of things when it comes to dementia during the COVID-19 era. And today I'll be talking about a handful of pieces that have come up over the past year. First and foremost, just talking about the state of COVID-19 in particular in Washington State, and how things are progressing and kind of a state of COVID as it is right now. Talk a little bit about what we know so far from the literature and the research regarding COVID-19 survivors and impacts on dementia and the limited data that we have so far, but I will touch on that. I'm going to spend some time talking about our qualitative study and the information that we found over the summer in terms of how COVID-19 impacted a lot of the social, economic, and otherwise the supports for our folks with dementia in Washington State. And then I'll launch more into some of the practical recommendations. And these are coming from a handful of sources, but some of them being driven by the CDC, but then also a lot of the things we have learned over the past year from our colleagues, people from other states, other ADRC research groups, as well as clinical friends across the country who have kind of put together their thoughts of what's been working for our folks with dementia. And then I'll leave you with a handful of other resources, whether they're for yourselves, patients with dementia, or their families as well. So let's first talk about what's going on currently with COVID-19. So it's in many ways difficult to even wrap your head around that 1 year ago today, not quite, was when one of the first cases was identified in Washington State. That was in January of 2020. It's amazing that a year has already passed. This is data as of last week in terms of cases by county and Washington. So we've had about 300,000 cases identified, as well as about 17,000 hospitalizations, 4,000 deaths over about a year's time at this point. And what we see when we break down this data into more of the demographic differences is we see a lot more cases in folks who are 20 to 40 years old or so. So they make up about 40% of all the cases in Washington. However, when we think about hospitalizations, deaths, more of the mortality levels, we're seeing much more significance on our older adults. So about 60% of COVID-related hospitalizations and 90% of COVID-related deaths are for people over the age of 60. So even though more people who are younger are actually contracting the virus, we are seeing a higher mortality and more significant or severe impacts on our older adults. And those proportions have held pretty well over at least the past 6 to 8 months. When we were looking at some of this data this summer, these were pretty similar, even though we were having smaller numbers overall. So in terms of what we know and what's been out there, I always put the caveat when I talk about this is that a lot of these studies are very preliminary. We're talking about kind of data on the fly right now, and a lot of research being ongoing and active. People are publishing, brief studies and smaller reports based off of findings so that it's going to try and help launch additional studies and more clinically useful information. So keep that in mind as I talk a bit through what we know. So SARS-CoV-2 has been associated with neuropsychiatric symptoms. You've probably heard about this through various mediums, But ultimately, we know that COVID-19 ultimately impacts the central nervous system. So a lot of the common symptoms that folks are reporting would include headaches. One of the known side effects or kind of symptoms of COVID-19 being reduced taste and smell, some of which does not always return or does not return to completely normal, as well as ataxia or broadly gait disturbance, altered mental status and delirium, mostly when people are in the ICU or who are experiencing pretty severe symptoms of COVID-19. And a lot of these have been talked about in the literature as ultimately components of multi-organ failure, a pretty severe response to kind of an overall compromised system. But we're actually, when you start to peel the symptoms apart, we're actually seeing that these are occurring even in people without multi-organ failure, or if we account for significant organ failure problems. We also know that COVID-19 increases stroke risk. And for anyone who works with older adults, we can appreciate the concern and severity that presents itself. But we know that increased stroke risk or incidence of stroke ultimately results in a long-term risk for cognitive decline or ultimately dementia. So when we think about the direct connection to COVID-19 and dementia, we don't have this perfect alignment, but we know that it increases risk for the risk factors for dementia. We also have seen a lot of the neuropsychiatric sequelae, especially in certain populations. So when people are having more comorbid conditions and then are contracting COVID-19 and survive, so things like diabetes or smoking, obesity, COPD, especially a lot of the pulmonary and respiratory conditions, we're seeing that the neuropsychiatric symptoms seem to be even more prevalent in these populations after recovery from COVID-19. We're also seeing a disproportionate representation of these neuropsychiatric symptoms in Black and Latinx or Latinx communities, more so than non-Hispanic white. And that's even after correcting for many of the other socioeconomic medical access factors that we often associate with just overall kind of greater comorbidity in these populations as well. So some of the earlier studies that we have so far have suggested that about 10 to 30%, so maybe about a quarter, would be a reasonable estimation of the ICU discharge for COVID-19 have some degree of cognitive symptoms. So about a quarter of folks who end up in the ICU as a result of COVID-19 are coming out with some sort of cognitive complaint. Now that could be anything from, you know, the broad catch-all of memory loss to poor attention or distractibility, but something is what they're reporting. If you're really interested in a deep dive, I highly recommend that paper that came out of the Lancet just not too long ago, I believe it was about 4 months ago, is a really good read for some of the in-depth pieces that they're trying to capture. One of the things we're also trying to drive from, because this is a novel coronavirus, is what do coronaviruses do in general? What do we know about them from a neurologic perspective in the past? And what we do know is that some of them can cause demyelination and ultimately neurodegeneration, usually related to this pro-inflammatory cytokine process, but also related to the secondary pieces of respiratory distress, hypoxia, a lot of those pulmonary respiratory issues that are occurring in the ICU. It still remains to be seen whether or not COVID-19 specifically will result in a very similar process. You know, kind of the data continues to roll in, and we're monitoring people of how they're doing after recovery, but more will be unveiled. If you are interested, or if you have patients or colleagues who are interested in more of the longitudinal studies, 2 very large studies are underway right now. The Alzheimer's Association has paired with the World Health Organization for a large global brain study for longitudinal monitoring of recoveries of COVID-19. And the other group, or the other large study, would be the NeuroCovid Biobank. This is being hosted by NYU in New York, but it's a large collaboration, and they're expanding their collaborations across the country to gather more and more data to understand this on a longitudinal and biomarker level. So I'll transition to some of the work that myself and several colleagues conducted this summer, looking at COVID-19 and the impacts on our state. So Washington State being a very diverse state when it comes to the kind of the access and socioeconomic differences between various counties, and just east versus west, north versus south. It's a very interesting place to live. And so our study wanted to try and capture some of the difficulties that were happening, not just in King County, where the vast majority of the population of Washington lives, but also what's going on in the other parts of the state, those that don't have as many people, but also don't have as many resources. So this is our team. We conducted a qualitative study funded by the UW Population Health Initiative, and this was mostly over the summer for data collection, but ran from January to November ultimately. And we are really focused on those care impacts and the service impacts of those who serve our people with dementia in Washington State. So we collected our data in this very tight window between July and August. We looked at online surveys of people with dementia, as well as the clients who serve them. And it was in a very large variety of organizations. So these included a lot of social services like area agencies on aging, senior centers, adult day health, things like Meals on Wheels, or transportation type services, access buses, things like that. But then also looked at healthcare. So different types of healthcare. So not just primary care or geriatrics, but we also looked at palliative care, hospice, as well as very specialized memory or neurologic clinics. And we conducted these one-on-one interviews with organizations, and in particular with organizational leaders who could speak to the larger impacts that COVID was having on the care for their constituents. So this is kind of how we broke it down. If you loosely break up Washington State into three sections, we have kind of Western Washington, Central Washington, and Eastern Washington. The lines are drawn in related to counties. And so we had a distribution that was reasonably distributed based off of population, given that the large majority of the population in Washington is west of the Cascades. We also were looking for a variety of different services that these organizations provided. So whether it was health education, whether they were doing transportation, providing meals or delivering meals, some sort of adult day health, or more of a care directed service, or palliative care. So some of the themes that came out of this, and a lot of these will probably not be surprising, but social isolation came up again and again and again. So I'll share with you a handful of quotes from some of our interviews that came about. So in this case, when we interviewed one of the adult day health leaders, they said that their folks with dementia were more withdrawn. They were less physically active. They're just overall less engaged. Ultimately, they're kept in their rooms a lot. And a lot of this, keep in mind, this was in July. So a lot of restrictions were still very, very tight at this time, probably more so than they are now. And so there was a lot more confinement that was happening during this period. Also a lot of challenges in terms of visitors and visitation. So families not being allowed to go in, see their loved ones, kind of this very difficult time with communication, of getting calls and being worried about their loved ones because they don't have kind of the resources that they have, or the ability to go to something that's more socially stimulating. So in this case, thinking about our folks who might go to an adult day healthcare center during the day, and that would give them that social engagement, that stimulation, and just get them out of the house and not having that as an opportunity. There's also quite a bit of comment about just physical deterioration. So because people aren't moving as much, they're confined to their rooms in many assisted living facilities or skilled nursing facilities, or for others who just have that 1-bedroom apartment, and they're being encouraged not to leave their home. You're seeing just more and more physical deconditioning. These are folks who are maybe typically going out for even a brief walk, or maybe they love to ride their bike. They're just not doing those things. And then ultimately we're seeing more falls, we're seeing greater fragility. And as we know, falls, fragility equals higher mortality. Another thing was an increase in more of the behavioral symptoms, and also a loss of cognitive function, seemingly kind of at the same time. So we heard a lot from caregivers of various organizations that and also medical health providers via their patients, that people with dementia were just expressing a lot more of these behavioral or kind of neuropsychiatric symptoms. So for those who may have had kind of a mild paranoid delusion around people stealing from them, or that people were watching them, it seemed to be exacerbated, that that they didn't have kind of an outlet or kind of like an ability to manage those symptoms as well. And one of the components that came up with this when we talked with providers is that providers were struggling because they had fewer non-pharmacological options to offer. So normally in our clinic, especially, we're very keen on non-pharmacological approaches rather than throwing antipsychotics at folks with dementia when they present with behavioral symptoms. And the literature supports that. Now, one of the challenges is that a lot of non-pharma approaches involve some sort of activity or some sort of opportunity to, move around or carry out some sort of activity, often with another person. So if we're in these restrictive situations, it's going to be a lot harder to execute something like that. And we can't be in a place to recommend it if it's not feasible, right? We need to be able to give somebody a feasible solution. So a lot of the providers were talking about relying more on antipsychotics and not feeling great about that. That this is what I have to offer, and I'm not. This wouldn't normally be my plan A. We also saw quite a bit, and people are still doing this. This is something that's still very, very salient right now, is delaying care. So things that people would normally pick up the phone and call their PCP and say, hey, you know what? This new symptom popped up. It's been bugging me for 4 or 5 days. I think I should make a quick appointment and come see you and just get it checked out just in case. We're seeing a lot more concern from providers because their patients have been waiting longer and longer and longer to come in for something that seemed benign, but ends up being quite a big problem because they didn't get it dealt with 3, 4, 6 months ago. As we know, now we're going on over a year since COVID showed up, and it's concerning, especially if we have conditions that need to be managed. So if, diabetes, hypertension, high cholesterol, all things that folks, especially elderly folks, need to have monitored to make sure that they don't lead to worse outcomes. In line with delaying care comes with making really difficult decisions about when to go in. So a worry that if I do go, if I do go into the hospital and something happens, maybe they catch COVID, maybe they contract something else, and maybe I won't see them again because of visitor restrictions, or there's some perpetuating other medical problem. So the idea that if I keep them home, they might not get the care that they need, but at least it won't be separated from them. And for those who have a very strong connection and maybe it's their only person or their only care partner, or they have a very limited family, we see some really difficult decisions being made and kind of tearing people apart. And I think a broader issue with that we heard from a lot of assisted living facilities or skilled nursing facilities was the communication problem. And I think this has improved, at least anecdotally from what I've heard from folks, is that this has improved quite a bit. And remember that a lot of our data was being collected kind of in early months, but a lot of poor communication around what to expect. So we had older adults with their loved ones with dementia who were in skilled nursing facilities or assisted living, memory care units, things like that, and just not getting information about whether or not they could visit, whether there were restrictions, whether their loved one was doing okay with all of this, or whether they were noticing changes. I think this is improving, and that's a really good sign. They found good outlets and good ways to communicate as the months progressed. And one of the last pieces I'll talk about is telemedicine, because I know that this is a very important opportunity to connect healthcare to people during the pandemic. And it's been a very mixed bag. So on one hand, telemedicine is fantastic. It has allowed us to address some of those concerns with people not accessing care, right? Because they can jump on the phone and I can stay home and I don't have to be at risk to myself or bringing something home to my loved one. So it's breaking down some of those barriers. And yet it's also very challenging, not just because of technology access issue, which would be another talk in and of itself, but also preserving kind of the humanity in telemedicine. And this is something that came up frequently for our palliative care providers in particular. So we have older adults, people with dementia who are in pretty significant compromise of their function, and trying to talk to that person or talk to the family through video just felt so disconnected from the humanity of what draws most of us to medicine, and being able to connect to our patients, to their families, and have that human connection that is so important. And I think this last piece here of saying, like, it didn't feel like I was giving him my full presence or my full attention. And I think that really, really hits the nail on the head. Does it feel real? And is the patient feeling that way as well? So some of the pieces, or some of the places where telemedicine has been working really well, though, were a lot of those outpatient non-urgent clinics. So we were seeing a lot of really great results for those brief check-ins, those 15 to 20-minute appointments where, like, most things are going okay, but you just want to lay eyes on someone, especially when there was some sort of tech support on the other end of how to get the person online, and whether or not there was somebody, an assistant to help with getting them onto Zoom, or Doximity for phone calls. Things that we ran into or saw were a lot of difficulty more with non-English speaking, especially with interpreters, and the challenge of crosstalk. As you know, in a lot of video conferencing platforms, it's very difficult for two people to be talking at the same time. And in particular, in interpreter and non-English speaking appointments, this is even more of a challenge as you kind of navigate a triangle of communication, and everybody needing to take their turn, and how long that can take, kind of extra time that can take. So there's silver lining to some of these things. There are very creative and brilliant people out there who have done marvelous work and have found some things that have really been beneficial during this time. We heard a lot about wellness checks, phone calls, newsletters, again, trying to break down those barriers in communication. You know, here's our senior center and this is what we're doing. We want to check up on our regulars. Our assisted living facility is sending out email blasts at the end of each day or at the end of each week to give an update on the broader scope of things. A lot of creative things in the social era or the social zone. So whether they were like drive-through social events, outdoor distanced picnics or things like that, a lot of collaborations between organizations like meal delivery and grocers, farmers markets to be able to deliver things and not waste food and also get food to people who need it. We also saw a lot of really great work of transitioning things online. And like I said, technology broadly has kind of been a mixed bag, but ultimately telemedicine was a bit of a savior in the past year. And getting the Medicare billing support was also extremely helpful to be able to reach out to a large number of our older adults and people with dementia. We transitioned a lot of online and phone support groups from their in-person groups that used to be present in 2019. And then folks have become more and more creative with using social groups and video conferencing platforms for things like book clubs and bridge clubs and things like that to stay connected. So I'm going to transition to some of just the practical recommendations. So things that hopefully are some pearls that you can take away that have been put out there as relatively successful. So one of my favorite organizations, the Alzheimer's Association, always has fantastic handouts. And one of the ones that I find particularly helpful for those who are working more in a, not just in a facility, but also can be used at home of reminders is this idea of a daily plan. So one of the things that came about with COVID-19 is the challenge of change, right? We all went from going about our normal lives to a very abrupt change in how we conduct ourselves every day in very normal activities. So this is extremely disruptive and what most have pointed to as the major challenge for behavioral symptoms in dementia because of that change. So establishing a new routine or implementing some sort of schedule can be really helpful, and it doesn't need to be complicated. Right now, a lot of our activities are not glamorous and complex. Instead, they're pretty simple, as you can see here on the daily plan example of just having a conversation over coffee, right? Taking a break for quiet time, doing a particular chore. Maybe it's just washing the dishes from breakfast. It doesn't have to be complex, but it gives a structure to the day. And that can be really, really helpful when they're not worried about what's coming next, is that we always have a place to look to determine what's coming next. In a similar vein is simplification. So when we're communicating, especially a lot of information rolling around right now, it seems like every few hours we're hearing more about the next thing with the vaccine or a treatment or a trial that it's a lot. It's very overwhelming, and considering how much of that we need at any given time. Earlier in the pandemic, I was talking about kind of information overload. I gave a talk on that, and it was a lot of people talked about how it was just too much all the time. And so I was like, what if you just limited to one time per day, right? And if that was at the end of the day, or it was in the middle of the day, but that was kind of when you absorbed all the information, right? And that's when you would just take it all in, and then you had time to process it rather than just being pelted with it all the time. I think another piece that rolls with that is the resistance that can come with distress and what we call from motivational interviewing, we call rolling with resistance, which is when we get a lot of pushback for change, and when things are challenging and stressful, we roll with it, right? Another way of doing this in particular with dementia is something we call use what the dementia gives, which we might get something out of the blue or something that we didn't expect, but ultimately it's a reflection of how somebody's feeling. It might not be a positive, but it's going to give us information, and we can use that, and we can use it in a positive way. Implementing some supportive statements as well. So when people are very distressed about, I'm hearing all this stuff about a virus, what's going on? We can have some little statements in the back of our pockets, like, you know what, we're doing everything we can to stay healthy right now. This is how we stay safe right now. This is, we're healthy and we're doing okay, and we're going to keep doing what we're doing so that we stay that way, right? So having some of those in your pocket can be helpful. hygiene and hand washing is something that's come up again and again because it represents a change in our typical pattern. Probably in 2019, we were not washing our hands, probably not enough, but we definitely weren't washing them as much as we are now. So again, that reflects a change in behavior, and change is difficult, especially for folks with dementia. So giving them ways to remember to do this or to prompt them to do this on their own can reduce the battles. So whether it's extra reminders like small notes on the bathroom mirror, or implementing just a hand washing practice. A lot of caregivers that I've talked with over the past year have found it to be helpful to just say, you know what, every hour we're washing our hands. Doesn't matter if we've been, inside all day. It's creating a pattern that will be helpful, especially if we do end up going out more, that will have kind of this already implemented idea that clean hands are important. And so whether that's using hand sanitizer is great if you're outside or not near a sink, but it gives you that routine, that structure. Another tactic that is often helpful for people with dementia is what we call illusion of choice. And this is not giving somebody an out for a task that is very important. So in the case of hygiene and hand washing, rather than saying, do you want to wash your hands? The question becomes, would you like to wash your hands with soap, or do you want to use hand sanitizer? Either way, they're going to end up washing their hands, regardless of which option that they pick. So if it becomes a concern around something more like safety or health related, we can use this to ensure that we have, we kind of keep the health pieces in check. One of our caregivers early on was getting very creative with different hygiene activities. And I loved one of the examples that she gave, which was when her husband who has dementia was very resistant to washing his hands so frequently. She would just put a handful of dishes, whether they were clean or not, or dirty, in the sink full of soapy water, and she would just have him clean the dishes. And so ultimately his hands are getting cleaned a bit from being in the soapy water, and it's actually giving him an activity to do. So this was a great opportunity to get her or get him to clean up his hands, and then also have an activity to do for a little while. So when we talk about the humanity in telemedicine, I was talking about earlier, some of the challenges that come up with that is some of the key points that we've learned, especially in working with people with dementia and older adults in general, is when you're conducting telemedicine visits, is really taking a few extra times for orientation and introduction. So easily we have become accustomed to Zoom and just launching into our meeting for the day, or even a telemedicine visit of some sort, because we're busy. But in this case, it's still a very novel and in some ways disorienting experience to see somebody on a TV screen or on a computer screen or on their phone that they normally would have seen in person, right? There's no precedence for my doctor is on my computer. And so giving them a little bit more of an opportunity of introducing yourself and doing a bit more of that orientation and introduction, maybe a couple of pleasantries as well. Also being very careful to treat that video visit like an in-person visit as much as you can. And recognizing that a lot of our typical tools are outside of our realm because we can't actually do a lot of our neurologic exam or something like that. We cannot conduct necessarily, or at least to the complete degree that we would previously, but do the best that you can to make it seem most like in person will get you a better result. It probably goes without saying, but turning on your camera whenever possible, talking to a name or a blank screen is going to cause more problems than good. And what can be even more helpful is getting rid of your mask if you can, to allow for more of the visual cues, and also for them to follow along if there's hearing impairment as well. One of the more challenging pieces with the way that a lot of our configuration is with our computers is looking into the camera and not down at your screen. You can do some adjustment of your camera ahead of time, but trying not to be somebody who's kind of looking down and all you're seeing is the top of your head can also help, again, kind of making it feel more in person and more connected. Speaking clearly, allowing for pauses, kind of even more so or more exaggerated than you normally would. This again goes back to the challenge with crosstalk, talking over people, or somebody starts to say something, it's going to garble about 5 seconds or so of that connection. And that can be really difficult and sometimes very frustrating for people with dementia, let alone anyone else. And then another technical piece is to try and use a headset if you have a lot of background noise, or if you know that the room that you're in is particularly echoey. And so if you can use a headset, you can eliminate a lot of the background noise. I know here in my office, we're not far from the helipad. And so that can cause some challenges when we're talking to patients and then a helicopter comes in. So if we can get our microphone closer to us, it can eliminate some of that. Masks. Yes, wear a mask. Yes. So they remain necessary even if patients and staff have been vaccinated. So CDC guidelines has not budged on any of this. Masks need to be placed on anyone who otherwise does not have problems like trouble breathing or is otherwise incapacitated. Ultimately, if you cannot take off your mask by yourself, you should not be wearing one, but that is a very slim number of people. Folks with dementia are probably going to have more trouble remembering to put their mask on or to keep it on. We run into this a lot in our clinic of patients wanting to take it off or not understanding why or remembering why they have to have it on their face. If worst case scenario, right, if you're outside with someone and they absolutely refuse, just remain as far away from other people as you can. There is some great signage that the CDC has put out as like printable PDFs for long-term care facilities or other facilities that have reminders for masks. They're very simple, to the point, they're pretty in color, that are easily downloadable and you can put around your facility for reminders. For all those chronic conditions, as well as new problems, just really encourage your patients to follow up for those issues so that we can avoid the problems down the line. And, the list goes on, but, all of our cerebrovascular risk factors, the things that are going to exacerbate dementia, cognitive issues and otherwise, keeping an eye on them. One that often gets overlooked is hearing loss. And we know from the data that hearing loss, untreated hearing loss, is associated with cognitive decline. And so it's something that we need to keep an eye on. It's something that we can treat and definitely worthy of going into the clinic for. If you have options for telemedicine, if that is a possibility, absolutely ask patients and their families if that's something that they're open to. Make sure that they have the capability to do it. So we run into some challenges every once in a while where patients will, say that, yep, I have a computer. They have a computer, but the computer doesn't have a microphone, or the computer doesn't have a video or a camera that's connected to it. So kind of being careful about how much you offer it to, and making sure they have the necessary equipment. Always provide those reminders for masks and hand sanitizing and hand washing. Encourage people to try and get roomed as quick as possible rather than sitting in waiting areas when and if you can, and trying to avoid a lot of the gathering spaces, especially like in the hospital or somewhere where you're going to have a lot of people moving around. What I've loved about the past year is the breadth of things that have come about in terms of social distancing, socialization. So we've seen a lot of folks who are trying to find ways to still stay connected. And a couple of my favorites have been things like the Sofa Singers, which is a group of people who have all have kind of like Zoom accounts, and they have been on a kind of a synchronized song that they all sing together, and it's pretty impressive. There's lots of ways to exercise together. People are using creative. This one photo on the bottom is a creative way that this is probably about this summer sometime. This group of neighbors would all go outside in the morning in their cul-de-sac. And as you can see, they're standing apart, but they would be kind of in there at the edge of their driveways, all doing some sort of dance together. I believe this day was the hokey pokey, but they would do something where it was a piece of socialization, a piece of physical activity. And it was something to just get people, just a little bit of a break from everything else that was going on. Writing letters, encouraging people to stay connected in whatever way that they feel that they can, often drawing or sending drawings. This is an app where folks can stay connected with their grandchildren, and they can read virtual books with their grandkids, or their grandkids can read them a book on the same screen, and they can share that together. So lots of really neat things out there. It's also important to remember our care partners. They've been through the ringer this year. It has been more stressful than I can ever imagine for them. And remembering them when we're working with our patients with dementia too. So encouraging those self-care practices. I know they've heard it, they hear it all the time, and they say, yes, when do I possibly have time for self-care? Put it into the routine. So if we put it into that schedule, into that daily plan, we're going to be more likely to do it, right? Than saying that, like, I'll do it later, I'm too busy now. Sometimes that means doing something before the person with dementia wakes up. Maybe it's while they're taking a nap. Maybe it's after they go to bed at night. It could be while they are doing something else. We were talking about they were doing some dishes earlier. It could be that while they're doing the dishes, they take a short break and go just have a cup of tea, but just ultimately scheduling that in. So those 5-minute distractors like washing dishes, sorting papers can just give them a chance to go reset and breathe when you have a very stressful day, encouraging them to just give some sort of task just to buy you a few minutes of time to just have that deep breathing and kind of reset before we go back into the rest of the day. A topic that's come up a handful of times is the risk and benefits of home-based care. And I think a lot of our folks with dementia and their families have navigated this pretty nicely, but the initial question was around, do I bring somebody else in to help with the care for the person with dementia? And is that an increased risk for me, given that I don't know who they have hung out with and kind of what their status is? But our main recommendation over the past year has just been ultimately contact that provider, understand the protocols that are in place, and ultimately understand your personal risk tolerance. So for some people, they absolutely need that break, that assistance, and that is worth the risk of bringing somebody else in. For others, their risk tolerance is not that low or that high. So there's definitely a personal piece here of how much risk you're willing to take. There's no right answer. There's no wrong answer, which makes it sometimes more difficult. For our long-term care facilities, and especially in visitations, some of the good information that's come out of the CDC has been talking about contingency plans and having checklists or a specific protocol for if something happens, this is what we're going to do. And this isn't just a mass, kind of a massive plan for an outbreak, but even something smaller, like one of our, just one provider may or may not be positive, and we're finding out, but they're getting tested, right? What are we going to do? And one of the things that is helpful is if you have contained information in one neat place about each of the residents. So about each person with dementia. And it's not just kind of their medical pieces. That's all important, but also things about them that in the event of an emergency are going to be helpful to know. So particular behavior patterns that they have, things that are particularly triggering for someone, and what's going to help. So if you're going to suddenly have a big change, an abrupt change in their routine, what's going to help calm them down? Because you might need to pull that out during this time. Strengths and capabilities as well. What are they still really good at? What communication works really well for them? These are also going to be super helpful when you run into resistance as a result of change and upsetting of a routine. When it comes to keeping friends, family involved as well, we heard great success in phone trees or email listservs, kind of some way to communicate information out so that everybody is on the same page. We understand we can provide details about what protocol is being executed and what to expect next. Should they expect a call? Should they expect an email? What's going to come next so that they're not waiting on kind of and stress. They'll have that information too. Just mobility. We were talking about how mobility, physical deterioration, how important it is for people to still stay up and moving. So providing safe spaces for walking and exercise, whether it's a designated part of the facility, whether it's access to a park that's nearby and maybe you're going as pairs or something like that. Creating some sort of structured activity during the day, whether that's like pairs who are doing some sort of exercise routine, or doing just outdoors time. Time and time again, we're seeing more articles about the importance of nature and just being outside, getting some sunshine, especially in winter, and how important that is. Behavior management, obviously proactive is definitely better than reactive. So I've talked many, many times at this point about routine, consistency, and structure. The more that we can have that, the better off our patients are. And creating a calm environment, having an appropriate amount of stimulation where we're keeping our folks engaged, but not to the point that they are agitated or irritated, right? And being mindful of that and monitoring. Again, those handouts are kind of the what I need to know about this person can be particularly helpful. Is this somebody who thrives for social stimulation, or is this somebody who can get pretty agitated if they're interrupted doing something, right? You can wait until they're kind of naturally taking a break. I'll touch on vaccines because this has come up since our vaccine rollout started. So ultimately, people with dementia and their caregivers are being encouraged to get the COVID-19 vaccine so long as there are no contraindications otherwise. That is coming down from the CDC. And it's for the reasons that people with dementia are often older adults, ultimately at higher risk, as we were talking at the very beginning about serious complications, and therefore better to have the vaccine than to risk contracting COVID-19 and resulting in those complications. And then also for the family caregivers as well. So if a family member, a caregiver, or care partner ultimately contracts COVID-19, then they can't take good care of their loved one or person with dementia if their health is compromised. So they act as a team. And I think this is a good take-home quote is that getting vaccinated is one of the most important steps that we can take to protect ourselves and our loved ones, just hands down. So vaccine rollout is ultimately state-based. This is Washington's vaccine phases and what we are currently doing right now. Presently, we are in phase 1B, tier 1. So we are in the second green bubble. So we are seeing vaccines given to people who are 65 and older or 50 years old who are living in multi-generational households. And then tier 2, 1B is next. And these are going to be a lot of our high risk or critical workers who are 50 or older. Ultimately, though, vaccines are not a replacement for social distancing, washing your hands, good hygiene, wearing masks, none of that. So yes, get a vaccine and still do all of those good behaviors that we have been practicing so nicely for the past year. And if you have if you want more information on that, go to your state's Department of Health website for specific COVID-19. A lot of them have some sort of sub page for older adults and those with chronic conditions. And so that's can be more detailed information for specific types of patients. And the Alzheimer's Association also put out a very nice kind of like 2-pager or so on the COVID vaccine in relation to Alzheimer's, and that link is down there on the bottom. So some just general resources for COVID-19 in dementia. There's lots of good stuff on the CDC website right now. The overall general COVID-19 website is the one at the top, but then there's more information about specific to caregivers and those with dementia and needing extra precautions and specific things that the CDC is recommending, a lot of which I referenced in this presentation, but if you want to dive in more detail. The Alzheimer's Association also has a lot of great resources, both the COVID-19 main website, as well as specific tips for dementia caregivers, as well as some specifics for long-term care and particular protocols that may be of relevance for those who are taking care of a lot of folks with dementia or who are in a memory care unit in particular. Our clinic, the University of Washington Memory and Brain Wellness Center, has also translated a lot of our support and resources to online platforms. So we are offering a number of things for virtual support groups, some educational series, social engagement during COVID-19, and they're all free. So we do some virtual coffee chats for people with memory loss, broadly, people with dementia. They occur on Tuesdays, and they're just kind of more of like a social group. It's not, I wouldn't call it a kind of a group therapy, but more so a conversational group to just keep people connected, often with a theme, and they're led by Mary Grace Becker. She's one of our social workers. We are also doing some virtual caregiver forums. So we have options for caregivers to come together, and this is facilitated by another one of our social workers to really talk through some of the issues. This is really more of a opportunity of discussing what's working, what's not, and to get some feedback for caregivers. We also have a handful of broad talks that have been put out over the past year. We created this virtual community wellness talks. We're now calling them Wellness Wednesdays, and we're paired with the Alzheimer's Association. We're doing these on Wednesdays of various topics, anything from stress management to nutrition, grief, different things with like sleep. So worth checking out. A lot of them are hosted on YouTube as recorded lectures as well, or the PowerPoints are there too. And then just some additional resources. So the Alzheimer's Association has put out a series of free webinars that are related to COVID care. I found these to be really helpful. There's a lot of different topics that have come up. One being some things that we talked about today. So self-care for caregivers, concerns with long-term care facilities, both from a caregiver end, but also from a larger institutional end of what long-term care facilities can be doing. Some legal considerations as we navigate some of the challenges with Alzheimer's in the context of COVID. So some of them are very COVID related and others are more general. So those are open to anyone. The 24/7 Alzheimer's helpline remains available to anyone. What I love about it is that it's staffed by counselors and social workers who are well-versed in dementia and can be helpful, not just to patients, but their caregivers or both at the same time. and they're often directly or can connect you more directly with local support as well. If you're working with a particular subtype of dementia, there are some additional resources. So the AFTD Association, so the Association for Frontotemporal Dementia, has its own website and is providing specific COVID-19 resources as they relate to FTD. So in frontotemporal dementia, as many of you know, we can see, at least in behavioral variant, one of the more common variants of FTD, we can see a lot more disruption in behavior, and becomes even more relevant for that disruption in routine that I've been belaboring here, and good strategies for that in a subpopulation who's prone to expressing a lot of the behavioral symptoms. Similarly, the Lewy Body Dementia Association also has a subsection for coronavirus and resources that they're offering. If you do not know about Teepa Snow, you should. Teepa Snow is lovely. She does excellent work on a lot of topics with dementia. But during COVID-19 era, she has been putting out some very nice practical videos on ways to engage, say, in hygiene and hand washing, or kind of behavioral management, stress reduction, both for patients and caregivers. So if it's not for you, passing on that information to somebody else may also be of benefit. So that is what I have for you today. I want to thank you all for having me and discussing dementia in the era of COVID-19, and I'm happy to take questions.
Sorry. We do have a question. The rush for getting the vaccine is becoming a problem. Are there any resources to vaccinate those living at home with mobility issues? And perhaps you can talk about other states, but I'm aware that some of these resources are state or region specific.
Yes. So yes, absolutely. This is a challenge. So we are seeing, at least in Washington state, your best information right now is coming from the Department of Health and the information that they'll provide. So the DOH website for Washington, I can't speak, my knowledge is exhausted in terms of, because it's state by state. So I apologize to those who aren't Washington state who are listening. One of the big challenges that has come out with the rollout, at least in Washington so far, has been a bit, and I believe this is just kind of described, kind of the free-for-all that we're in right now. There are, if you have somebody who is kind of savvy, especially tech savvy, because we are running into a big issue of people needing to access or schedule appointments, but they're all being done over the internet right now. And that's a big challenge to those who aren't tech savvy, don't have the technology at home, or just don't know where to go to sign up. So if you can pair with someone to help with that. I'm not sure what folks are doing specifically, because part of the question was for mobility issues and vaccine at home. Is an excellent question. And for those who are not in a living facility, I have not heard, let me put it that way, I have not heard of a specific organization that is heading up kind of more the mobility challenge and getting vaccines to people at home. But it makes me really want to look it up now. Yeah. Sorry, I can't be more helpful. I wish I could.
Do you know of any sleep disturbance sequelae of COVID-19?
Excellent question. A little bit. So there's report of more challenge in people who are, especially who had pre-existing sleep difficulties and those being exacerbated by COVID. you've probably heard some of the phrases like the long haulers, or those who are experiencing like long and drawn out sequelae. We're hearing a lot of sleep difficulties for seemingly different reasons, whether it is just kind of headache, kind of a secondary piece of it's difficult to fall asleep because, I'm having a raging headache. But yes, there definitely are reports of sleep issues presenting themselves in different ways, but a lot of difficulty falling asleep and staying asleep, and so, as well as kind of secondarily, I guess, then the daytime fatigue also being, but that's even present even when sleep is good at night. Yeah.
So I actually was wondering, you had some very nice information about long-term care facilities, but I'm wondering if you might speak to people who maybe are delaying an admission into a long-term care facility, or sometimes people being pulled back into the home from a long-term care facility, and any suggestions or thoughts about that?
Yeah. So excellent question. So when folks are struggling to make that decision, I think one of the pieces, and I think I was talking about this earlier, is kind of weighing your own risk and understanding protocol. And I think data gathering is going to be your biggest task here, and understanding. So if you're talking about maybe it's time to have somebody go into a long-term care facility, but I'm just not sure whether they're whether the protocol is good enough for me, is gathering that information, having a very candid conversation with the long-term care facility about what they're doing and whether or not you're comfortable with it. I've heard from a handful of patients more recently that they are that some care facilities, or even kind of like 50 plus apartments, are actually not even allowing people to come in. So they're withholding any new residents. So that's something to also just be aware of and inquire about. I think on the other side of people being pulled out, this was a very hot topic kind of as we saw that first spike kind of in April, and people being really worried about, is it safer if I leave my loved one in the assisted living facility, or do I bring them home, right? And there's not a right and wrong to this question, because you're weighing the difference between the risk of potentially harsh protocol of kind of restriction and social isolation while they're living in the facility, and possibility of exposure and spread. But then usually there was a reason why you made that leap for the person to go into assisted living. And it might have been that your ability to care for them independently was not adequate, or kind of that your ability is not quite there. It was beyond what you could do on your own, and that's what led you there. So I think having an honest conversation with yourself about, could I still do this? Because for some people, when they're talking about bringing their loved one home, they've been in a living facility now for over a year or more, right? And they're kind of out of touch with kind of how much work this is going to really require, and are they physically and mentally capable of doing it, and is that worth the risk versus exposure? It's not there. Again, there's not a good, just easy answer. None of this is easy answers.
Great point. Have long-term care facilities in Washington created visiting stations, like where visitors can safely visit with their loved ones, with gloves, maybe a tunnel through partition, that sort of thing?
Yeah, some of them have. I've heard a handful of creative solutions. So whether it's kind of like you said, like visitation bubbles, or like visitation tents outside, which with our weather lately, that's hit or miss. Yeah, some facilities have been definitely more lenient. We've seen a very large array of what people are doing, permissing, and we've come a long way, I feel, from just having, window visits and people waving. I think we're getting more and more creative. I heard one group that was doing, like these little bubble, or these little, they kind of look like little lean-tos, like little tents outside, and they had little picnic tables in them. And so you could it was just you and your loved one, and you had your little tent, and then, which not like a camping tent, not on the floor, but on a little table. And then there was another one that was on the other side of the lawn, and then another one, and you kind of like rented the space, so to speak. You had it for your period of time during visitation hours, and then they would sanitize and everything like that, and then they'd move in another group. So, which to me is much better than nothing, and still following a decent kind of hygiene protocol.
For those with persons with dementia with delusions and paranoia, any suggestions about how to address getting the vaccination?
Oh my goodness, what a difficult question. I think, a lot of those safe messages you're talking about earlier of having kind of conversation around, like, this is important to stay safe. This is what we need to stay safe. I think talking about it as this has come up in conversation lately about whether to kind of call it, just kind of generally calling it medicine, and whether that is rather than a vaccine, and whether that's deceptive or doesn't sit right. And I know this is a struggle, because we, especially when we talk about patient-centered care, we don't like to be deceptive, misleading. It doesn't feel right. It doesn't feel okay. And yet right now it's extremely important. So I think having more of those encouraging messages around safety, definitely making sure that we're not bringing up this type of conversation when somebody is obviously agitated, or bringing it up at a time where they're more calm and are willing to kind of listen or have a conversation around it.
Could you speak a bit more to the incidence of ataxia as a COVID symptom, and how that can impact people with dementia, like increasing fall risk or whatever?
Mm-hmm. Yeah. So yes. So ataxia being one of the symptoms that has come about, kind of in the literature anyway. And yes. So if it's not that it comes about in everyone, right? So we're talking about folks who have kind of these perpetual sequelae of symptoms after COVID, and that ataxia can present in some and increase fall risk. So if we're having folks who are already at risk, they already have some sort of motor difficulty or balance problem, I think it's important for those to be kind of evaluated more specifically for balance, whether it's going to be beneficial to have them do something like physical therapy, whether they're going to need more support or monitoring at home or in the long-term care facility, and maybe modifying their treatment plan to include more of that assistance, or having assist present for transitions, transfers, things like that in particular. So if it does present, I think it's worth kind of some additional eyes on, because what's difficult to say is that we don't know yet how long some of those symptoms are going to hold. We just don't have the data to say it, or to indicate that, oh, most of the time this goes away. We just don't know. So we can hope, but in the meantime, just, give that support for what they need to kind of decrease the fall risk. So whether that's increased precautions or some sort of intervention, depending on the person.
And sorry, I may have missed it, but could you repeat or mention how common ataxia is as a symptom?
I would be hard pressed to give you a number off the top of my head. It is in one of the studies. I just don't remember the exact prevalence. Maybe I'll go out on a limb and say maybe 10%.
Okay.
That sounds about right, but that might not be accurate.
And Julia actually mentioned that although it's a small sample in Alaska, she said their elders with dementia have been much more pro-vaccine than the staff. And that the elders kind of remember the patriotic vaccine campaigns of the past.
Yes.
With sort of positive emotions.
Oh, fantastic. Yes, I was talking with a colleague earlier about kind of that the patriotic nature of vaccination kind of in the past, and like as you know, kind of wishing we had kind of this rally around that right now. That's so good to hear that's working. So perhaps, I mean, that's another approach to, you know, kind of if you have somebody who can latch on to some of that, you know, as a strategy, especially if you're in a facility where, you know, if you get one on board, right, maybe you can get a couple more. Yeah, kind of that like, oh, Joe, it wasn't that bad, you can do it too. That I could see. Oh, that excites me.
Yeah, I actually had a conversation that kind of grew among all sorts of people when I was getting my vaccine, because we were all talking about remembering the polio vaccines.
Yes, yes, yes. Yeah.
Have you had experience with speech sequelae from COVID-19, stuttering, speech generation, aphasia?
Not specifically. I have more from I have heard more from like a word finding kind of difficulty that we can often think of as kind of a non-specific cognitive symptom. I haven't heard much by way of aphasia, with the exception of if as a result of COVID-19, we also, resulted in, infarcts or some sort of, TIA stroke episode or something like that. I've heard of it more in those more extreme cases where COVID-19 was one of the reasons why we were in the hospital and then triggered more significant vascular event. But I haven't read much about aphasia as just a kind of a typical sequelae so far.
Any other questions? I'm getting a lot of chats about how useful and helpful this information is, how much they appreciate the resources. All right, then I think we'll say thank you, thank you, thank you. This just really has been useful, and we really appreciate it. Have a good evening, everyone, and we'll see you next week.